Let me talk you through what I would anticipate would happen to you on the day of your surgery or the morning of your surgery if you were having a cystectomy here at the Royal Berkshire Hospital as part of the cystectomy team. So we ask you to come up first thing in the morning, and we do often do 2 operations in a day, but we ask all our patients to come up first thing in the morning because we like to see you as the surgical team. We like, the anaesthetists like to meet you, and the nurses staff like to get things prepared. So we often get you up here very early in the morning, but you'll meet the nursing team. They may give you some pre-meds. You'll meet the anaesthetist that's going to be looking after you during the course of your operation, and you'll meet the surgical team, whether it be myself or one of the other members of the team, to go back through a consent form and a consent process with you and to check that you're happy and your next of kin's happy. And then we get you ready and we get you changed and we walk you down to the theatre complex. So to do a cystectomy is traditionally done through a midline wound, midline laparotomy, which is quite a big scar going through the front of the abdomen. And the traditional approach to surgery is the surgeon is scrubbed up, is sterile, and the surgeon's hands with instruments are inside the patient. And that's changed a lot over the last few years, particularly here at the Royal Berkshire Hospital, where we're one of the leading centres in the UK at advanced robotic surgery and advanced robotic reconstructive surgery. And it's very exciting because it allows us to do operations to a far higher level of detail than we could ever do with our hands and with our naked eye. The operation is still done by the operating surgeon, but by controlling much smaller instruments that are within the patient to do the operation on a far higher detail. One of the greatest advantages of robotic surgery is the detail and the zoom that you can get from the optics. And if you can see what you're doing with surgery, then you can deal with a much higher level of accuracy. At the end of the robotic camera, 2 high definition lenses that give an individual feed into each eye. So as I'm sat on the console, I have a stereoscopic view inside the patient. And that gives me a 20 times zoom into the patient that I wouldn't be able to see with my eye. And what's fantastic is that that also correlates to a 20 times scalable movement. So a movement within a millimetre that I can do with my naked hands, I can do 20 times greater with the robotic instrument. And that correlates with the zoom. So as I zoom in, I can do higher and higher levels of accuracy with surgery. And now we're seeing things with surgery that we would never see with our own naked eye. So the transition from open surgery has moved to laparoscopic keyhole surgery, and that keyhole surgery has transitioned into robotic surgery, and we are now beyond a level beyond that still, where we're doing everything entirely robotically within the patient. The difference between doing standard keyhole surgery is that the fulcrum of the instrument is very close to your hand and actually amplifies any small variations in movement. With a robotic instrument, all the movements happen right at the tip of the instrument. So the fulcrum of that instrument is within a few millimetres of where you're operating. The other huge advantage with regards to robotic surgery is the blood loss. Now with open surgery, and the abdomen is open in the operating theatre, then you're operating at normal atmospheric pressures. We have some very clever, complex ways to administer high gas pressures within the abdomen to create the space where we operate, but also that is higher than the pressure of the blood within the veins, which is, from a surgeon's point of view, if you have to detach a vein from a vessel, then as you open the vein, the blood will stay inside the vein because the pressure of the operating atmosphere is higher than the blood inside the vein. And that allows me as a surgeon time to then suture up that vein very delicately and carefully using some different sutures, to then point when we get back to normal atmospheric pressure, the vein is closed. So all the blood stays in the right place, which is just where you want it when you're having an operation. So instead of open surgery where blood loss was a concern, we now are operating on patients that we would never have otherwise deemed fit to have an operation because of the advance in robotic surgery.
Hello, I'm Dr. Edward Todman. I'm one of the consultant anaesthetists who works with the cystectomy team here at the Royal Berkshire Hospital.
And I'm Claire Ware. I'm clinical lead for urology theatres.
So we're just going to run through what you should expect when you come into the anaesthetic room and ready for your operation. You'll come in and we have to perform some patient safety checks. We'll get you to sit down on the anaesthetic table and we'll put some monitoring on you to ensure safety during the operation. We'll then perform a spinal anaesthetic, and when that's in the right position, we'll get you to lie down on the anaesthetic table, give you some oxygen to breathe, and get you ready to go off to sleep in preparation for your cystectomy.
While you are in the anaesthetic room, the nursing team will be preparing the equipment that the surgeons will use to perform your operation. And that would involve instrumentation specific to Robbie the robot, and more straightforward instruments that we would use for abdominal surgery. After you have gone to sleep, you'll be wheeled into the theatre on the trolley and transferred to the operating table. The operating table has pressure relieving mattresses, and we will position you safely and comfortably using as many gels as necessary to protect you. We will perform a shave on your tummy to allow surgery to take place, and you may have a shave on your leg, which is where a plate will go that will also ensure your safety during surgery. Towards the end of the operation, we will close your wounds with soluble sutures, so they dissolve, and you will not therefore need to go back to your doctor to have your sutures taken out, but the wounds will be covered with skin glue, which will allow you to have a shower afterwards. You'll have a drain coming out of your left side, which will just stay in perhaps till the following day, and then that wound will be allowed to close. When you wake up in the recovery room, you will have an oxygen mask on your face, which will be delivering some oxygen to you as you wake up, and you'll have the lines and the drips in place that the anaesthetist put in the anaesthetic room before you went to sleep. You'll also have some compression leggings on your legs, which will be squeezing every couple of minutes, and they're there to protect you from any clots forming. We do it for every patient who's having major surgery like you have, and it's absolutely completely normal, and they will probably stay on for a day or two. In the recovery room, you shouldn't have any pain, but if you do, please just tell the recovery staff and they will get you some painkillers and make you more comfortable.
I was in surgery I went in 9 o'clock in the morning, so I didn't have, funnily enough, I wasn't worried about it, I don't think.
And I got a phone call from Charlesworth later that day, about 5 o'clock, saying surgery's gone well, don't think there's any point in you visiting, he's flat out. And we'll see you in the morning, you know, you can come and visit him. But as far as they were concerned, surgery had gone well, which I thought was really nice.
They had to have allowances made for you to go into intensive care unit, just in case anything had gone wrong. But in my case, I was lucky. I didn't even have to go into intensive care. So after, I think, was probably a 7 or 8 hour operation side, which was by the actual Robbie the robot, that eventually back into the ward and everything was fine, you know, sort of, they said, do you want painkillers, sedatives? No, nothing at all, you know, so it worked out pretty well.
I was obviously got ready with the sort of the robe, got out of my sort of own clothes into a robe and sort of just sat in a chair by the bed and talked to my wife really until it was time for me to go down and be knocked out before before I had the operation. Strange waking up because you're sort of you're in the recovery room at the time, and it seems as if it was seconds or minutes ago that you were sat up in bed or sat outside the theatre actually, about counting down from 10 down, trying to get to 9, 8, 7, down to 1, but you don't get past 5 if you're lucky. And really you're not aware that 5 or 6 hours has gone by.
Effectively, I was just prepared for the operation. It was explained to me that it wasn't really a trolley down to the theatre. One went for a walk. And everything, as we entered the operating theatre, was explained, and why it was that, you know, there was limited space for everything that was in there, and it was a case of just relax and let things happen.
And I can remember going into the room where you lay on the bed and they give you the anaesthetics, etc. They were so brilliantly kind, very professional. There was about 4 of them in the room, and the guy that did it, I don't know why I remember this, but he was an Ace Chelsea fan, and he started talking to me about that. They clearly do that just to get your mind off of what they're doing. But he was a lovely man, and then, as just been described already by an earlier speaker, they sort of put an injection in your back, and then by the time you counted to 10, well, you didn't get to 10.
I believe, if I remember rightly, I was one of the first on the list. So I was done quite early in the morning, given an anaesthetic, or wheeled down to theatre, given an anaesthetic, woke up in the ward.